Okay, we are live. Good afternoon, everyone. Today's session is going to be really helpful and it's led by Dr. Shri Harika Bonam from Apollo Cradle and Children's Hospital. She is going to talk about International Women's Health. So stick around until the end and ask us questions if you have any. Doctor, you have the stage.
Thank you so much, Hirani, for the introduction. On the occasion of Women's International Health Day, it's going to be on May 28th. So, today I'm just going to talk about two important topics on women health. First thing is heavy menstrual bleeding, and the second thing is contraception. So, after finishing each topic, I'll just give a pause or a gap of 1 or 2 minutes, couple of minutes, and if somebody has some questions, you can just post in the chat box or you can ask me. Okay. Yeah. So the first topic is heavy menstrual bleeding. When is it significant? So usually every month we get periods, and every time we get period, we don't know how much amount of blood we are losing. Few think that whatever they are losing is normal, and they think the flow is normal, and they come after a couple of years saying that they have become anemic and the hemoglobin has fallen because they're not actually aware how much bleeding is heavy. So the word heavy menstrual bleeding, it is a subjective word because you cannot objectify what is the amount of bleeding in each and every menstrual cycle by just measuring the amount of blood loss. So the burden, we are discussing about this topic today because the burden is so much that this heavy menstrual bleeding, it accounts for nearly 30% of the gynec consultations in our day-to-day OPDs. Okay. And then it is also an important cause for absenteeism from school as well as absenteeism from work, and this also lead to multiple number of complications, and it leads to fatigability, and it causes loss of concentration, it causes hair loss and numerous other health problems. And according to statistics, 1 in 3 women will be affected with heavy menstrual bleeding. And among women who have heavy menstrual bleeding, 2 out of 3 they will end up in having iron deficiency anemia or anemia because of excess blood loss. So this heavy menstrual bleeding can impact the ability to follow iron levels, and it can impact our day-to-day activities, and it can impact our quality of life. Women can present with headache, they can present with easy fatigability, they can have hair loss, poor concentration, or feeling cold, all those things, which few of them which we have already discussed. Now, what is a normal period? So, whenever we ask what is a normal period, I see most of the women answering that if they get period dot on the same day, like every month, if they get a period on same date, like 30 days cycles is what they think is normal. But it is exactly not like that because it is not math, and of the day it is science. So, when we say heavy menstrual bleeding, as per the definition, anybody who is having a period regularly in between 21 to 45 days. That means if you have a period once in every 21 days, or once in every 30 days, or once in every 40 days, or up to once in every 45 days as per the recent recommendations, we call it normal period. This is how frequently you're getting period. Now when it comes to the flow, how many days flow is normal? So few think it is only 5 days or 3 days, but actually any flow which lasts between 3 days to 7 days is considered as the normal flow, normal duration of the flow. So exactly on dot 28 day cycles, only 16% of the women will be getting exactly on dot 28 day cycles. Most of the women will be getting between 21 days to 45 days. Okay. So now what is menorrhagia? Menorrhagia is nothing but a medical term for heavy menstrual bleeding. So this menorrhagia is a term which has, it's a science term. Okay. Now when we say heavy menstrual bleeding, any blood loss which is more than 80 ml per cycle, we call it heavy menstrual bleeding. But this is an objective way of measuring. You cannot measure the amount of blood loss which somebody is happening in each menstrual cycle. Now there are different subjective ways of knowing if your bleeding is heavy or not, depending upon what method of menstrual hygiene you're following. That means some women they use tampons, some women they use sanitary pads, some women they use menstrual cups. So depending upon their profession, depending upon their comfort and the feasibility, each woman chooses different types of methods to manage the menstrual cycle. So now, depending upon what method you're using, we'll have to calculate how much flow is heavy. So normally, according to the dictum, if you're changing your sanitary pad every hour or once in every 2 hours, that means you're having a period. heavy bleeding. Let it be pad or let it be tampon. If you are soaking it fully in 1 or 2 hours, that means it is heavy. To talk in a generalized manner, anything or any bleeding which is more than 4 or 5 pads per day roughly, or one pad being soaked completely in less than 1 or 2 hours, means you are having a heavy bleeding. Now coming to the menstrual cup, usually menstrual cup, it will take roughly about 4 to 8 hours to fill it up, and if it is getting filled up more frequently, so then that means you're having heavy menstrual bleeding. And not just the a number of pads, or not just the amount of blood in the menstrual cup. If you're having significant amount of bleeding, or if somebody is having the amount of bleeding which is more than their previous cycles, like say for example, previously they used to soak only 2 pads per day, and now they last 1 year or last 6 months they have been observing that they are soaking 4 or 5 pads, or they are having the symptoms like fatigability, or if it is affecting its quality of life. Though it doesn't come into this figures which I have told, but still if they feel that when compared to the previous cycles now their flow has increased, then even that means that they are having a significant or heavy menstrual bleeding. And also there is a mnemonic that 7 to 1 is the mnemonic. If somebody is bleeding or the blood loss is lasting for more than 7 days, in medical terminology we call it prolonged menstrual flow. So having just 1 or 2 pad soap, but you are changing the pants for more than 7 or 8 days, means that you're having heavy menstrual bleeding. Any flow which is lasting for more than 7 days, or if you're changing a pad in less than an hour or less than 2 hours, or once in every 1 or 2 hours you're changing a pad, or if you're passing clots the size of which are more than 1 inch, in all those situations this means that you're having heavy menstrual bleeding. Now having said about that, now we'll go into what are the causes for the heavy menstrual bleeding. So now the causes could be again structural causes, it could be hormonal causes. The most common things are the structural causes. When it comes to structural causes, the most common cause will be either uterine, that is the cause related to the womb, or cervix, are the two main things which are responsible. So, in the uterus, uterine fibroids, these are non cancerous growths which can develop within the lining of the womb, or on the wall of the womb, or outside the womb on the lining of the womb. So, these fibroids, these are non cancerous growths, but they tend to cause heavy bleeding, especially if they are lying inside the lining of the womb, and they could be responsible for the menorrhagia or anemia. And now the second important cause is polyp. Polyp is nothing but whenever your lining is too thick, the lining tends to form folds, which we call polyps. And these polyps, they tend to cause irregular bleeding or intermenstrual bleeding, and it also tend to cause heavy menstrual bleeding in some. So structural causes being the most common causes. The next important structural cause, which I didn't mention in this slide, is ovarian cause. Sometimes ovarian cysts, especially if they are hormone releasing ovarian cysts, sometimes they might be responsible for the heavy menstrual bleeding. And then coming to the cancerous causes. The next important cause will be uterine cancer and cervical cancers. They also tend to cause heavy menstrual bleeding. Okay. And then next is the hormonal imbalance. As you must be hearing about PCOS quite often. PCOS is nothing but a hormonal imbalance, which is mainly caused because of the insulin resistance. So in polycystic ovarian syndrome, we have actually a criteria called Rotterdam's criteria. Any women who is having irregular periods, like once in every 2 or 3 months, or having features of excess male hormone like acne, or excess hair growth on the upper lip, or having dark nape of the neck, all these things are features. And then if somebody is having in the scan polycystic pattern in the ovaries, if any two of these criteria are being fulfilled, we call them having PCOS or polycystic ovaries. According to the evidence, 1 in 3 women are having this PCOS pattern in the scans nowadays when you when you perform an ultrasound of the pelvis. And roughly 1 in 4 women, they are having this polycystic ovarian syndrome. So this polycystic ovarian syndrome and other hormonal problems like abnormal thyroid, all these things also are some of the important causes which can cause heavy menstrual bleeding. The next important thing is medical causes, which are really not that common. They are rare causes, but yes, if somebody is having abnormal liver function, like they're having a liver failure or they're having a kidney failure, so they tend to have heavy menstrual bleeding, because the clotting factors being generated in the liver. If somebody is having liver failure, they tend to bleed a lot because of the imbalance in the clotting factors. So, and then coming to the iatrogenic causes, when we say iatrogenic causes, these are causes which are from outside, like somebody is taking some medicine for some cardiac problem, like blood thinners they have been consuming, or there are some anticoagulants which they have been consuming for some other reasons. All these drugs they tend to cause heavy menstrual bleeding. So that's why these things also should be checked when we are treating a woman with heavy menstrual bleeding. On the top of it, if somebody is already anemic, that is, if they already have low levels of hemoglobin, they also tend to have heavy menstrual bleeding and hence the low level of hemoglobin, or whatever is the underlying cause for the heavy menstrual bleeding that has to be corrected. Okay. Now we are going to the investigations. How do we evaluate a woman who comes with a heavy menstrual bleeding after taking a thorough history? Most of the times, by having a history itself, in nearly 60-70% cases, we'll be able to come up to a diagnosis. But the rest one third, to know what is exactly the cause, we may have to go ahead with certain blood tests and ultrasound. Now, in the blood test, what we usually do is, one is hemoglobin, to see if you have had a lot of blood loss and you can and if you can cope up with just with oral iron, or you will require a support of any IV iron, or if the hemoglobin level is very less, sometimes we may advise for blood transfusion. And then the next important test is, we advise for thyroid and basic tests like sugars. And if there is a suspicion of PCOS pattern, we may ask extra PCOS investigations, and accordingly we'll treat you. Then coming to the ultrasounds, ultrasound is nothing but a imaging method which we do to look at your womb. How is the lining of the womb? How thick is it? Is there any polyp? Is there any fibroid? Any abnormality in the cervix? All those things we see in the imaging, that is ultrasound of the pelvis. Any ovarian cyst, all these things we see to rule out the structural causes for the heavy menstrual bleeding. Next, coming to the treatment, it could be either medical treatment or it could be surgical treatment. In medical methods, we again have pills. There are different types of pills, non-hormonal and hormonal pills. So when we talk about non-hormonal pills, the first line, usually when somebody comes with heavy menstrual bleeding, we give a medicine called tranexamic acid. So this is a medicine which increases the tendency of blood clotting and hence reduces the chances of you having heavy menstrual bleeding. We roughly ask you to take it thrice a daily for the initial few days. And if somebody is not responding to the non-hormonal medication after completely investigating and seeing what is the cause, and if we find that there is no obvious structural cause that need to be treated, or if we feel the structural cause is really not that major, in those situations, or if we see that there is no contraindication to prescribe hormonal medication, after seeing all the criteria, and if we feel that you're suitable to take the hormonal medication, the second step is going for the hormonal medication. Again, in the hormonal medications, we have two different types of pills. One is the combined oral contraceptive pill, which you can see here in the image, in which you have both estrogen and progesterone hormone, which has to be taken for 21 days, and then we give a gap, and again we give it for 21 days, and that cycle keeps on going. And then the next important thing is progesterone only pills. This is a pill in which there will be only one hormone, which is called progesterone, and which can be also given in a cyclical manner, or it can be given in a continuous manner. Okay. And this is about the pills. And if somebody is having polycystic ovarian syndrome, or if somebody are obese or are on the overweight side or something like that, we usually ask them to also lose that extra pounds, and we ask them to come into their normal BMI range, so that weight loss itself will correct the cycles in nearly 60 to 70% of most of the women, in women with especially polycystic ovarian syndrome. So lifestyle and then the pills or the medical treatment are the first line of treatment in case of heavy menstrual bleeding, which we usually try for the couple of months. And if it is not responding, then we go ahead with the next line of management. And then the next line of management is usually a hormonal device. All of you must be knowing a copperty, or must have heard about a copperty. Copperty is nothing but a T-shaped plastic device which we place inside the womb for contraception or a birth control, as a birth control method. But this intrauterine hormonal device which we use for the heavy menstrual bleeding is slightly different. This is also T-shaped device, but instead of the copper which is present in the copper T, here in Mirena, we have a hormonal coil. So we have something called levonorgestrel. It is a hormone which will be the hormone will be present on the stem of the Mirena, and this will be placed inside the womb. And this can be left inside the womb up to 6 to 7 years, and then this releases the hormone locally. and this will tend to shrink if you have fibroids within the wall, or it tends to shrink the lining of the womb, and it tends to reduce the amount of flow which you're having in the periods. And sometimes with the Mirena, few women, roughly in about 50 to 60% women, they tend to have very scanty flow or spotting, and nearly 50% women, they don't have any flow, which we call amenorrhea. That is 2 3 months. Sometimes they just go without having any menstrual periods also. So this is Mirena. And then in women who have high risk factors, like who are having heavy menstrual bleeding, along with that, if they have high risk factors like being obese or being overweight, or if they had history of polycystic ovarian syndrome, or if they had his family history of endometrial, that is cancer of the womb, or if they have too thick lining of the womb, which is evident on the scan, or women who are not responding to this first line management like pills or any other treatment options, in all those women we may have to take a biopsy from the lining of the womb and see it under microscope to rule out the rare possibility of having cancer. So these risk factors are all risk factors, and women who have these risk factors, sometimes these women are more prone to develop endometrial or cancer of the womb than compared to the women who don't have these risk factors. So after giving initial medical management, if we feel the women are not responding, or if they have any of these above mentioned risk factors, we usually place inside the womb a straw-like catheter, and we take a biopsy of the lining of the womb, and we see if they have any chances of precancerous changes inside the lining of the womb, which eventually can go or convert into malignancy if not treated on a timely manner. Okay. And then women who are not responding to the medical management, who are not responding to the non-surgical options like Mirena, that is the intrauterine hormone device, or women who had an endometrial biopsy which we have taken and it is showing some abnormality or precancerous changes, in those women, or the uterus of the women has become so big and it is causing pressure symptoms, or in all those women we usually advise them to go ahead for a surgery. So when surgery is indicated, again there are two main types of surgery. One is if you have a fibroid, and if the fibroid is the main cause for the heavy menstrual bleeding, the fibroid alone can be removed, or if there are multiple fibroids and the age of the women is more than 45 and they have completed the family, and or previously have tried some other surgical management with which they didn't have good response, in all those women we give the option of the removal of the womb. So now here in most of the situations, whenever a decision of surgery has been made, there is a big dilemma between if you have to go ahead for removal of just fibroid or removal of the womb. And whenever you have that dilemma, and whenever your gynecologist is giving you an option of choosing between removal of the womb versus removal of the fibroid, it is always wise to go ahead for the removal of the fibroid. Because see, there are many areas or many cities, many towns, even in our country, where the women, most of the women who have crossed the age of 30, they don't have the womb, because there is a myth, or few women they tend to think, or not just women, people in certain areas they tend to think that womb is a vestigial organ. Once done with the kids, you can go ahead for the removal of the womb. It is actually not so. Uterus is a very important organ. Though you're done with your pregnancies or kids, most of the times if you go ahead for hysterectomy, your ovaries also shrink within few years after finishing or after removal of the womb, which can lead to early menopause. We call it surgical menopause. That is around, if you have your hysterectomy done around 33, 34, after 3 4 years, your estrogen levels will fall drastically, and eventually you end up in early surgical menopause. So you will be more prone to develop cardiac problems, you'll be more prone to develop vaginal dryness, difficulty in having intercourse with your partner, skin wrinkling, hair graying, hair loss, all these problems you'll be more prone. So all the advantages which women have over men are mainly because of estrogen hormone. If you go ahead for a hysterectomy at a younger age thinking that the uterus is a vestigial organ, you'll end up in losing the estrogen hormone, which is a healthy hormone, and it could be more harmful, and you can end up with osteoporosis, that is weakening of the bones, which can lead to fractures at a younger age. So always whenever your surgeon is discussing about what type of surgery you have to go ahead whenever you have fibroids, please be wise and discuss with your surgeon or discuss with your gynecologist with your gynecologist and think about both pros and cons and accordingly take a call. So always women who are less than 45 years, and if there is a big fibroid, it is preferable to go ahead for removal of fibroid alone. If the woman has crossed 45 years of age, or if there are multiple fibroids and previously already had a surgery, or had multiple comorbidities like cardiac problem, hypertension, diabetes, you cannot have anesthesia again and again, you cannot get operated again and again, so you want to go ahead for hysterectomy, then that is a different choice. So you'll have to see what is the clinical situation, and then you'll have to decide on what surgery you'll have to go ahead and get it done. And now, this is about the surgery. And whenever we talk about the surgery, there is also one important thing which I want to tell about the surgeries here. Surgeries are again of two types. It could be an open surgery or it could be a keyhole surgery. Whenever you have an option, or your gynecologist is giving you an option of going ahead for a keyhole surgery or a vaginal surgery when compared to the open surgery, always better to go ahead for a vaginal surgery or a keyhole surgery rather than an open surgery, because in vaginal or keyhole surgeries the blood loss is less, chances of complications are less, the recovery is fast, early discharge, better satisfaction, and very less chances of you having any further complications. So think about those things whenever you're taking a call for surgery. And then there are also other options. Non-surgical advanced procedures are being available for fibroids, which are the main cause for heavy menstrual bleeding, which includes, one is uterine artery embolization. The image which you're seeing on the left side is nothing but uterine artery embolization. In this image, you can see that there is a fibroid, and you can see that the main vessel which is supplying the uterus, we call it uterine artery. And this uterine artery, into this uterine artery through the femoral artery, catheter will be placed, and this catheter will be adjusted into the uterine artery, and small emboli particles like gel or foam kind of particles will be released into that place, which eventually block the small vessels which are arising from the uterine artery. And these vessels which supply the uterus and fibroid eventually will get blocked and the fibroid shrinks. And this procedure is called uterine artery embolization. A radiologist, especially interventional radiologist, will do this procedure for you if you decide to go ahead for this kind of advanced procedure. But in this procedure, if three women go ahead for this procedure, two of them most of the times will be okay, but one third women, they again can have certain complications at a later date and may eventually land up in a removal of the fibroid or hysterectomy in a later date because of not having symptomatic relief. And then in the right side image, you're seeing something. This is nothing but MRI guided focused ultrasound. This is nothing but an MRI guided procedure in which ultrasound waves are focused into the fibroid, and this will cause lysis of the fibroid. This is an even more advanced procedure with very limited number of studies which have happened, and then the more research has to be done to actually make it more applicable in our country. Okay. Yeah. So take home message in this topic is mainly how much flow is heavy, when to consult an obstetrician or gynecologist, and what are the different treatment modalities available. I hope most of you are clear with all those things. So any doubts so far? Any doubts so far? Shivani, anything from your side? Okay, so now we'll go ahead with the second topic. The second topic of today is contraception. Contraception is nothing but birth control. Why is it important to talk about this method? So, because we don't want unintended pregnancies, because consequences of these are very high. It is not just the physical health, the mental health also will get affected if somebody has unplanned pregnancy. So I see in my clinic that few couple come with pregnancy, and not every time I am in a situation to congratulate them, because I will be very happy the minute they say that it's a positive pregnancy test. I'll be ready to say congratulations, but I had to first ask, is it okay for me to congratulate? Because some women or some couple, they come with unplanned pregnancies, and whenever they come with unplanned pregnancies, MTP is not a small thing. We'll have to take your consent. We'll have to give a couple of medications, and after that bleeding, and then we'll have to monitor, and then we'll have to do a scan. Sometimes in scan you tend to have retained products, and then we'll have to again advise that you'll have to go for a surgical evacuation. So this procedure is a definitely traumatic procedure for both the gynecologist as well as the couple. So it's always better to avoid unwanted pregnancies rather than going ahead for a medical termination of pregnancy. So that is the reason why we are mainly talking about this. Talking about few numbers, awareness, only 40%, according to statistics, only 40% of women in our country, they use effective methods of contraception. And the awareness about birth control method options are only 50 to 60% women in our country. They are aware of the available contraceptive methods, and the effective methods only 40% of women have been using. So why do we advise women to have birth control methods, use birth control methods? It is to avoid unwanted pregnancies and thus improving your physical and mental health. But it is not always just the responsibility of the women. It is the responsibility of the couple, because there are different methods which even the guy can try. So we'll go ahead and discuss about different types of methods available. So first is natural methods, the other one is barrier methods, and then temporary, we can divide them into temporary, permanent methods, and the emergency contraceptive methods. So these are the wide different range of methods which are available. We'll discuss about each one of them. But when you have so many methods, the first and foremost doubt which everybody get is which one to choose, which method you have to choose, which one is the safer method, which one doesn't have complications. These are the different doubts. So which one to use, it mainly depends upon how serious you are planning to use your contraceptive methods. So why I had to write this line here, because I see a couple of women who are recently married, and they're okay even if they conceive, but they are thinking that they want to give a 1 year without, they want to go ahead with 1 year without having pregnancy, and they want to just settle first and then plan pregnancy. In those situations they can use condom, because they are not really very seriously trying or planning to avoid pregnancy. Few women, they say we are okay even if a pregnancy happens accidentally, but yeah, we want to avoid it for 1 year, but we are really not serious about it. In those situations you can try a condom, because condoms, they're very good in preventing sexually shared infections, but the failure rate is very high. So that is why, if you're seriously planning to use a contraceptive methods, the best method should have less failure. Okay, we'll discuss about which methods have less failure. And then if you have any associated menstrual problems or not, that is important, because few methods, they tend to cause irregular bleeding, they tend to cause little heavy bleeding and all. So that's why if you have associated menstrual problems, we give few methods which tend to reduce the amount of flow. For example, Myrina, the one which we are discussing, a plastic device which is a hormonal device which we place inside the womb, can also reduce the menstrual problems and can also act as a birth control method. So if you have any other associated menstrual problems, to help you with coping up with the symptoms of menstrual problems, we can give a method which can be dually useful as a birth control as well as a, excuse me, can you answer this phone call, as well as a method to treat your heavy menstrual period. And next, any other associated medical problems. If you have any other associated medical problems, high blood pressure, diabetes, or blood clots in the legs, in those situations, we will not be able to give all the methods. Like example, pills are contraindicated in those situations. So we have to see if you have any other associated medical problems. And next one is, do you want to have protection from sexually shared infections? If you want to have a protection from sexually transmitted infections, in those situations, condoms are the best method. But as I already said, condom has a very high failure rate. So if you want a very good control with protection against sexually shared infections, then you will have to use a double method, which is called a Dutch method, which is nothing but a pill combined with the condom. So we'll go into details. First is again the natural methods. Natural methods, there are mainly two types of methods: basal body temperature method and cervical mucus method. Here you can see something called calendar method. So this calendar method, mainly this calculates what is your fertile period. Usually a woman who has 28 days of cycle, initial 5 days when you're having flow, you will not be fertile. And in 28 day cycles, we say day 10 to day 18 is roughly the fertile period. We ask a woman to calculate her last 6 months of cycles and plot them on a paper. And based on that, we ask them to calculate which period is fertile, and we ask them to avoid planning intercourse in that period. So that is exactly what it is, calendar method. Now coming to cervical mucus method, based on the mucus discharge what you are having during your menstrual cycle, any day when you have your cervical mucus discharge or vaginal discharge, those days are considered as your fertile days. So we usually ask them to avoid having intercourse in those days. And the other one is basal body thermal temperature method. In this, we usually ask women to check their temperature as soon as they get up from the bed. And this is because after ovulation, they tend to be a rise in the temperature. So based on that, we usually calculate your fertile period. But all these methods, they have a very high, all natural methods have very high failure rate, which could be as high as 30 to 5%. That is, in 10 women who are trying this method, 3 to 5 women they can have a failure of the method and they can end up in pregnancy. So natural methods, the advantage of these methods is there is no medication, so no side effects of drugs or something. But the disadvantage is the failure rate is very high. The next important method is barrier contraception. Barrier contraception can be a female condom or a male condom. As the name suggested, barrier means it prevents the sperm from fusing with the ovum. So, this method, here you can see the first one is a male condom on the left topmost side, and then the female condom. These two are the most commonly used barrier methods. And then right side you can see there is a diaphragm. So this diaphragm is also a barrier. So the different types of barriers you can see, could be a condom, it could be a cap on the cervix, it could be a diaphragm with the spermicide together can be combined. Spermicides are nothing but the medicines which should be applied on the surface of a barrier, like on the surface of a diaphragm or inside the vagina, and then together along with the diaphragm, this can increase the chance of increase the effectiveness of the method. But again, these barrier methods are also not really highly effective. Barrier methods could have a failure rate of as high as 10 to 15%. That is, 1 in 10 women, they tend to have accidental pregnancies because of slippage of condom, or because of tear in a condom, or because of the sperms which are present in the precum. In all these situations, you may end up in accidental pregnancies. So the advantage of this method is they can prevent the sexually shared or sexually transmitted infections. But disadvantage, one more disadvantage is coitus dependent. That is, at the time of intercourse, that barrier has to be placed, and it can have an emotional, or it can even affect with your orgasm or with the libido as well at the time of the intercourse. Then the other temporary methods which usually we see are combined hormonal pills, which contain both estrogen and progesterone, or only progesterone pill. And then there are also certain injections which contain progesterone. All these methods are very highly effective. And then we also have a copper T, which is a copper containing plastic device placed inside the womb, or a hormonal device, which we discussed, Myrina, or an implant which will be placed on the inner aspect of your upper arm, which is called progesterone implant. All these methods are highly effective, but each method has its own pro and con. So we have to select depending upon the side effects and suitability, and then only we can prescribe. But they are very highly effective. The failure rate of all these methods which I have mentioned here are very less. They are less than 1%, to generalize. But the least failure rate we can see here, the least failure rate is with implant and an intrauterine copper T device. So now we are talking, now when we are talking about the combined hormonal pill, it contains both estrogen and progesterone, can be taken continuously or sequentially. Failure rate, as I have discussed, with all these methods is less than 1%. But you cannot take this pill if you have associated medical problems like migraine, or you're obese, or smoking, or high blood pressure, or you have had a history of blood clots in the legs for yourself, or blood clots in the legs in your family. In all those situations, combined hormone pill cannot be taken. Now, progesterone pill, the disadvantage of this pill is that it has to be taken daily on the same time. And even if you miss the pill for few hours, there is a chance of release of egg and you can conceive. Otherwise, with progesterone pills, the chance of side effects are less. You can have little mood swings, breast bloating, weight gain, and all. But otherwise, major side effects are very less with this progesterone only pill. Now, in the hormonal contraception, as we have already discussed, there are different methods. It could be pill, it could be implant. Implant is seen in the implant is a device which we place in the upper inner arm, which I have already told here. You can see in the image, and then the injections, and then the intrauterine device. There are also certain patches and vaginal rings which we don't actually use much in our country, but yes, still they are available. If your gynecologist is well versed in prescribing them, you can definitely opt them as well. The so far what we have discussed, all these methods are temporary methods. That means they are reversible methods. Once you stop using them, except for the implant and except for the injectables, the rest all pills, once you stop using them, the chance of you conceiving will come back to normal from the next month onwards. With the implant and with the injectables, they could be little delay, but it will not be beyond 1 year after stopping the method. Now, coming to the permanent methods are irreversible methods. Once you go through this method or you have this method, later the chance of conceiving will not be there. You cannot reverse them. Reversing them is a very difficult task again. Now, the permanent methods in male, what or in men, what we do is a vasectomy surgery where we tie off the vas deferens. Vas deferens collects the sperms from the testis and they transit the sperms through them. So vas deferens are tied off, and this procedure can be done on OPD basis without an incision. It can be just done by just giving a stab incision, and there is a no scalpel technique as well, and it is highly effective. The failure rate is very less. And then the next image which you can see is a female's in the female, what we do the sterilization or the family planning method, which is called female in female, which is called tubectomy. So now when we say tubectomy, fallopian tubes are the organs which or they are the place where the egg and the sperm meet and the embryo or the fertilization happens, and then from there the embryo travels and it reaches the uterus, and there it gets implanted. So once you tie off this fallopian tubes on both the side, which can tying off, it can be again literally tying with the thread, or it can be banding through a laparoscopic method. It's a keyhole method, which has more benefits. Either ways, you are blocking the place where the egg and sperm are going to meet. So definitely, most of the times the success rate is very high of this procedure. The failure rates are less than 0.4 or 0.5%. Failure rates of vasectomy are even more less. They are 10 times less when compared to the failure rate is 10 times less in vasectomy when compared to the tubectomy, and the side effects are also very less in vasectomy, or the complications are very less in vasectomy when compared to the tubectomy. Now coming to the last topic, double Dutch method. Double Dutch method is nothing but using two methods of contraception at a time. Your mainly primarily method of contraception here is hormonal methods of contraception. This is mainly an effective method of contraception, but combining it with condoms just because you wanted to have an added effect of prevention of sexually shared or sexually transmitted infections. So here the advantage is contraception as well as protection of yourself from sexually shared infection. Now, emergency contraception, few of you must have heard about something called morning after pill or I pill or unwanted 72 or all those things. These are nothing but emergency contraceptive methods. They contain high dose of levonorgestrel or uliprestol. That is, they contain a kind of medications which prevent the implantation, and few medications which prevent the release of the egg. So the primary method of action in emergency contraception, the pill is mainly to prevent the release of egg. They delay the ovulation or they delay the release of the egg from the ovary, and they always have to be used only as a backup method. So that's why there is something called golden window. When there is unprotected sexual intercourse, up to 72 hours you can take this pill. Uliprostol pill can be taken even up to 96 hours. But remember, these pills are effective only in the initial 14 days, provided you have a regular 28-day cycle. Because once the egg release happens, the main mechanism of these pills is by preventing or delaying the release of egg. So once the egg release has happened, these pills cannot prevent the implantation of the baby. Okay, so if you have had an unprotected sexual intercourse after your day 14, or you're sure your egg release has already happened, do not take the pill because it will not work. So then the only thing which works in the initial 5 days after the release of egg is intrauterine copper device. That is nothing but copper T, which prevents the implantation when taken within up to 5 days of the expected day of release of egg. But if it has been beyond, or if the intercourse has been beyond that, and if you are worried about it, do not try anything on your own. Just come to the gynecologist. The doctor will calculate or take a detailed history and then prescribe which is safer. Okay. So anything else? Any other doubts? Shivani, any further doubts, Shivani? Right. So thank you so much, one and all, for attending this session.